Good morning, dear students. Today's lecture's topic is diagnostic of syndrome, presence of fluid in the pleural cavity. By the way, what does it mean, pleural effusion? Pleural effusion is a fluid accumulation in the pleural cavity, and this is common medical problem in clinical practice. And as for these images, you can see the upper image, you can see the scheme of pleural effusion. This is the accumulation of excess fluid in the pleural cavity, and in the below image, you can see plain chest X-ray of patients with pleural, right-sided pleural effusion. Mechanism of accumulation of fluid in the pleural cavity. There are several mechanisms. First, maybe due to increased vascular permeability of the parietal pleura, it leads to increasing in capillary hydrostatic pressure in the visceral and parietal pleura. Also, there is increasing the amount of protein in pleural cavity. The fluid accumulation can be the result of violations of the outflow of pleural fluid in the lymphatic vessels. Also, patients, they can have pleuritis due to decreased oncotic pressure in blood plasma. These are vast majority of patients with nephrotic syndrome, for instance. Next mechanism, decreased intrapleural pressure. Patients with atelectasis due to bronchogenic lung cancer or sarcoidosis. And also we notice that in carcinomatous pleuricity can be a combination of several mechanisms. Pleural effusion can be subdivided in transudat and exudat. In transudat, there are changes in systemic factors, as for instance, systemic or pulmonary capillary pressure, plasma oncotic pressure, etc. And these factors, they affect the movement of pleural fluid, and they lead to formation of pleural effusion. Patients with exudat, they have changes in the pleural surface itself. Changes in the pleural surface itself develop, and it leads to an increase in the protein content in the pleural fluid. And also we notice that transudat is usually typical for patients with cardiovascular disorders and stage of heart failure, in patients with nephrotic syndrome, cirrhosis, in patients with hypoalbuminemia. As for exudat, we suspect pneumonia, cancer, tuberculosis, or viral infection in patients with exudat. By the way, the nature of exudat depends on the rate of exudation. The effusion in the pleural cavity is moderate in these patients. The liquid part of it has time to resorb, and fibrin falls in the surface of the pleura. That is, fibrinous pleuricity is formed. We usually suspect dry pleuricity. Or other clinical case, the exudation rate exceeds the outflow rate, then the liquid part of the exudate accumulates and serous fibrinous or serous pleuricity forms. At the same time, during the reverse development of the process, the liquid part of the effusion has been absorbed, and fibrin is organized with the formation of connective tissue adhesions. We use definition mooring lines up to the full obliteration of the pleural cavity. And other case is the exudat is infected. So in these patients, we suspect onset of purulent pleuricity or empyema pleura. causes of pleural transudate, we stratify all causes to 3 main subgroups. First group, very frequent reasons. These are usually we suspect transudate in congestive heart failure in patients with cirrhosis, complicated by ascites, hypoalbuminemia, peritoneal dialysis. Second group or subgroup of causes of pleural transudate, they are usually less frequent: hypothyroidism, nephrotic syndrome, mitral stenosis. The prevalence of these factors are less, and very rare causes. They can be related with constrictive pericarditis, compression of the superior vena cava, or urinothorax. Causes of pleural exudates also have been subdivided in very common, less frequent, and rare causes. Very common, they are typical malignant diseases, tuberculosis, parapneumonic effusion. Less frequent causes: pulmonary infarction, rheumatoid arthritis, autoimmune diseases, pancreatitis, post-infarction syndrome, Dressler syndrome. And rare causes may be due to medications, side effect, and fungal infection. Also, we take into account the possible iatrogenic etiology of pleural effusion, and there are the most frequent causes of pleuritis can be related with using of amiodarone, nitrofurantoin, phenytoin, methotrexate, and also other medications. When we speak about pathology of pleura, at clinical setting, we notice a systematic approach for patient examination with a minimum of invasive investigations, and we take into account the necessity of careful assessment, clinical assessment, and gathering full information about complaints of patients and especially medical history. Clinical symptoms, as a rule, the appearance of pleural effusion can aggravate clinical manifestation of some diseases. First of all, we notice the close relationship between the worsening of patient's condition and amount of fluid accumulated in the pleural cavity. These two parameters, they are directly proportional to each other. The inflammatory process in the pleura preceding the exudation of the fluid manifests itself in the form of pleural chest pain. And as it accumulates, patients start to feel heaviness in the chest, shortness of breath, palpitations, weakness, and dry cough, sometimes with poor sputum. At clinical setting, we take into account the objective examination, data obtained during objective examination, and the below mentioned symptoms. First of all, we notice weakening of voice, jitter. At percussion, we usually find out dull percussion sound. Auscultation, we can listen to weakening or absence of vesicular breathing, and fewer fluids can only be detected by X-ray or ultrasound. During objective examination, we can find out appropriate changes during using palpation, percussion, and auscultation only in patients with a large amount of fluid in the pleural cavity, usually more than 500 milliliter. At percussion, we perform percussion, and we can find out dull percussion sound above the pleural effusion. As for percussion, the upper limit of the determined dullness is called the Ellis-Damaso-Sokolov line. This at right image. This is Ellis-Damaso-Sokolov line in patient with right-sided pleuritis, and the left image Ellis-Damaso-Sokolov line in patient with left-sided pleuritis. And this line, above mentioned line, it goes from the spine up outwards to the scapular or posterior axillary line, and then anteriorly downward. The percussion boundary can be defined not along the real liquid boundary. It is important, but at the level at which the liquid layer is thick enough to shorten the sound, while the upper edge of the exudate is horizontal. The second step of diagnostic process is using of instrumental confirmation of the presence of pleural effusion. And we also apply to laboratory investigations. We refer patients' blood specimen to complete blood count, and results of the CBC test largely they depend on largely on the manifestations of the underlying disease characteristics. We usually find out neutrophilic leukocytosis with the leukocyte shift to the left and increase erythrocyte sedimentation rate. X-ray examination is necessary and helpful for confirming diagnosis. We can usually find out homogeneous darkening of the lung tissue with a clear oblique upper boundary, and mediastinum, at this clinical case, mediastinum with a large amount of fluid shifts to the healthy side. X-ray signs of pleural effusion. So in manifestation of pleural effusion in plain chest film, we must take into account the volume of pleural fluid in the pleural cavity. Changes on a direct radiograph as a rule appear when there is approximately 200 milliliter of fluid in the pleural cavity. In less volume of fluid, we use lateral radiograph of the chest organs, and lateral chest X-ray can help to detect the pleural effusion starting from 50 milliliter of fluid. X-ray signs of pleural effusion, we notice several symptoms. First of all, look at this image, image A. We can see free pleural effusion. This is left-sided pleural effusion. This is frontal view, posterior, anterior, or frontal chest X-ray. We can see many signs in middle left effusion. And other images, image B, small bilateral effusion. This patient, small bilateral effusion causes blunting of both posterior costophrenic angles in lateral film, posterior costophrenic angles. And image C, in the posterior anterior view, frontal view, only minimal blunting of right lateral costophrenic angle is seen. So, and at this table, we can see the appropriate liquid volume of pleural effusion and findings, appropriate findings at X-ray, chest X-ray. This is clinical case with left-sided exudative pluricity and due to tuberculosis. Ultrasound scanning. Ultrasound scanning is very helpful instrumental test during determining of the volume of pleural fluid. Ultrasound is a more accurate method than direct radiograph of the chest organs. Moreover, ultrasound is free of X-ray exposure. Ultrasound approach is also used to detect pleural effusion and differentiation of effusion and pleural thickening. And an additional advantage of ultrasound is the ability to use portable ultrasound devices. We can use this device in heavy patients with heavy condition. These are clinical cases of patients with pluricity. On the right radiogram, on the radiogram on the right, paradoxically along the auxiliary lines, along the fourth 8 ribs, an intense shading with a clear, even outer contour is determining lenticular. Thickening of a layer is 23 millimeter, and lungs are straightened, and lung tissue without focal and infiltrative changes. Ultrasound examination of the pleural cavity on the right. So this is ultrasound imaging obtained from ultrasound investigation. The encased is determined by encased fluid with dimensions of 30 by 60 millimeter with clear even contours. Its structure is heterogeneous. You can see here, large-celled with massive fibrinous adhesions. These are fibrinous adhesions. And pleural layers. And we put diagnose right-sided paracostal and cysted exudative pluricity. Other instrumental tests, CT scan of the chest with contrast is, of course, CT scan is superior to conventional radiography of the chest because it can provide more accurate imaging. And also CT scan is useful for determining the size and location of the delimited effusion. And CT often helps to differentiate between benign and malignant pleural thickening. These are imagings of the CT scan of the chest. We can see pleural effusion. Looks like a plot of low X-ray density. CT scan of the chest with contrast is more useful because it shows more accurate imaging, and here we can see a CT scan of the chest with contrast showing large left pleural effusion. And with associated areas of airspace opacity related to consolidation and or atelectasis. Fluid at the left cardiophrenic sinus sulcus appears to be loculated. The next step of diagnostic process, this is the identification of the cause. To confirm the etiology of the disease, we do pleural puncture and refer the exudate, the fluid pleural effusion to laboratory test. We can find out, we can confirm diagnose, we can confirm exudate or transudate. And this image is showing the position, correct position of patient. and we use this procedure with special needle, and also we do this procedure under the local anesthesia. The thoracentesis is indicated in patients who have a fluid layer thickness on radiographs in the prone position greater than 10 millimeter or have a confirmed confined pleural effusion detected by ultrasound. This slide is demonstrating the characteristics of transudate and exudate, including macroscopic and microscopic characteristics. We refer pleural effusion specimen to laboratory. Differential diagnosis of exudate and transudate. For differential diagnosis of transudate and exudate, it is necessary to measure the protein content in the pleural fluid. This is enough if the patient has a normal level. By the way, the normal level of the protein in the pleural fluid starting from 25 and up to 35 gram per liter. About light criteria, we use light criteria. They propose light criteria means assessment of the protein in the pleural fluid, and we assess the concentration of lactate dehydrogenase, and then we can evaluate the ratio of lactate dehydrogenase, pleural fluid, and serum lactate dehydrogenase. And lactate dehydrogenase of pleural fluid exceeds 2/3 of the upper limit of the normal serum lactate dehydrogenase. Analysis of composition of the pleural fluid. We notice lymphocytosis. Lymphocytosis, this is the possible diagnostical sign of pathology of malignant lesions and tuberculosis. We can find out eosinophilia. Eosinophilia is not reliable test for differential diagnosis of pleural effusions. We use also glucose level concentration. It is less than 3.3 millimole per liter in these appropriate diseases: NPM, rheumatic disease, systemic lupus erythematosus, tuberculosis, malignant tumors. And we take into account amylase rising. It can be in patients with acute pancreatitis, rupture of the esophagus, ectopic pregnancy, the rupture of the pipe, and a malignant tumor. And this slide is demonstrating the percutaneous pleural biopsy. It is not routine test. This is invasive test. It can be indicated for diagnosis of suspected granulomatous and malignant pleural lesions. And it is always necessary to perform a biopsy in the pleura for tuberculosis, regardless of the timing of the biopsy. And we obtain tissue specimen, tissue sample, and we refer this to culture analysis. Next method of investigation, this is thoracoscopy. This subsequent histological diagnosis is usually used when less invasive techniques, thoracentesis, percutaneous closed pleural biopsy do not provide diagnostic information. Next method of investigation, fibrobronchoscopy. This method of investigation is indicated for rare cases, for patients with presence of radiological signs of neoplasm, decreased in lung volume, history of hemoptysis, possible aspiration of foreign bodies. This slide is demonstrating a list of literature I have used for current presentation. Thank you very much for attention. We have finished.